And I have 11 o'clock, so we'll go ahead and get started. I'm Becky Royer, and I'm the lead for the Flex Quality Networking Council meeting today. I lead the Medicare Beneficiary Quality Improvement Project for the State Office of Rural Health. And so just want to welcome everyone and glad you could take the time to join us. The session today will be recorded, so I'll send out the recording link after the meeting, and then you're welcome to share that with others in your organization. We recently sent out an inquiry. Becky Sanders with the Upper Midwest Telehealth Resource Center and IRHA and I were preparing for the Critical Access Hospital convening meeting that will be on April 22nd. And telehealth has really ramped up this year, played an important role in addressing COVID issues and patient issues. And so we wanted to provide that topic during the session, but wanted to hear what you most needed to learn about, and received great responses back, and there were definitely some reoccurring themes. So we thought it was too much to cram into the call convening meeting, and so we divided it up into a three-part session. Today's really kind of part one of what we're calling a telehealth series. Today we will discuss school-based telehealth and with Kathleen Chominiak. And then we will build upon what people had requested to learn in part two during that Critical Access Hospital convening meeting on April 22nd. And at that time, Becky Sanders is going to be covering a telehealth Indiana update in general and some reimbursement updates, and share some of the challenges that individuals have and how to overcome that. And then we'll also have a part three session that will be May 26th. It's actually our next May Flex Quality Networking meeting. It will be on a Wednesday rather than a Tuesday, but we will be talking about clinic-based telehealth, kind of discussing some of those best practices, workflows, and reimbursement issues and waivers that have come about because of COVID, and kind of some things to expect in the future. Nicole Watkins with IRHA will be presenting that information too. So IRHA has kind of been our go-to organization for telehealth needs, and they've done a great job. Before we begin today, I do want to thank Allie Orwig with IRHA for supporting Zoom. I want to thank Joyce Fillenworth and David Conrad with the State Office of Rural Health for all of the work that they've done to support the call center, to support the programs, and to support the vaccine clinics, but also all of the hospital staff that have really gone above and beyond supporting the COVID vaccine clinics. What a great job everyone's done, and you all have a lot to be proud of and have heard a lot of great feedback with the efficiencies of people being vaccinated. So we'll get started today. Everyone is muted. You can unmute yourself by clicking the red telephone underneath the participant list. And then you also can click your space bar on your computer if you're listening on and through your computer, and that will temporarily unmute your phone, as well as you're more than welcome to chat in questions, and we will make sure that those are addressed and taken care of. You also can press *6 if you're using your phone. That will both mute you and unmute you. But if you have any issues, just let Allie know. You can click on the chat button if you hover at the very bottom of the Zoom screen, and just chat her to let you know if you're having any type of audio issues. So we'll go ahead and get started then. And I'm really excited about today's program. We're going to be talking about school-based telehealth networking. And I have with us today Kathleen Chominiak, and she serves as the project director at the Indiana Rural Health Association. She disseminates a lot of information and tools to help provide greater access to care for rural populations, which is extremely important. And Kathleen has over 7 years of project management experience and community outreach, so she's well versed in this area. She also works with the Upper Midwest Telehealth Resource Center along with Becky Sanders, and they work very hard with the rest of the team to improve rural healthcare access through implementation of telehealth programs. So as you're working on your telehealth programs in your hospitals or your clinics, they're a great resource. So if you have questions, feel free to reach out to me and I can connect you with them. And Kathleen will also be sharing her contact information as well. So Kathleen, I'll turn it over to you.
Yeah, thanks, Becky. It's great to be with you all today. My main audience usually is my husband, my dog, and my almost 8-month-old. When I looked at this presentation to update it, the last time had been in 2019, which blew my mind because 2020 was like almost nothing happened in regards to school-based. So I'm excited to be able to talk about this again today, and especially to folks that can have a legitimate conversation back with me. So please ask any questions as we're going through, or make any comments as you would like. So like Becky said, this program is under the umbrella of the Indiana Rural Health Association. And the Indiana Rural Health Association, we're just a not-for-profit organization with our main office out of Washington, Indiana. We also have satellite offices in Terre Haute and Indianapolis. And our mission is really simple. We're just trying to improve the health of all rural Hoosiers. And of course, a huge piece of that is access to care. We have various programs under the IRHA, but I'm going to speak specifically about the Indiana Rural Schools Clinic Network today, which we refer to as ERSKIN. But before we dive into that, I do want to mention one of the programs called the Upper Midwest Telehealth Resource Center that has allowed us to feel really comfortable in getting involved in telehealth endeavors overall. So IRHA houses the UMTRC as well, and there are actually 12 regional telehealth resource centers across the country, and the UMTRC is one of those. We represent the LILAC states that you see here, which are Illinois, Indiana, Michigan, and Ohio. And of course, if you're in a state other than that, there are other telehealth resource centers that can help you out, which you can see from this map. There is also the Center for Connected Health Policy and the Telehealth Technology Center. And those are two national resource centers that focus respectively on policy and technology. So collectively, all 12 plus the 2, so 14 of those telehealth resource centers are funded by HRSA, Federal Office of Rural Health Policy, under the Office for the Advancement of Telehealth. Again, speaking to the UMTRC, those that work for the telehealth resource centers have a wealth of telehealth knowledge. The UMTRC is able to provide information in a number of ways, and a couple of those are, one-on-one consultation as needed, as well as education at various events the UMTRC attends or puts on. We do host a 2-day educational conference every year in July. We also host workshops, virtual office hours, educational events. And then we do have a new podcast called The Virtual View, which you can find if you go to our website. We also have, which is really exciting, a telehealth demo and training center. So if anyone has been interested in getting their hands physically on any telehealth equipment, that is located in Indianapolis. So I wanted to put that out there because that is new and something that we're really excited about. So if you want to know more about UMTRC, you can check out our website at umtrc.org. We also have LinkedIn, Facebook, and Twitter if that better serves your needs for staying updated. So now that we've covered a huge reason that IRHA felt comfortable getting into that telehealth space, let's take the focus back to ERSKIN, which again is that school-based telehealth network. So the main goal of ERSKIN is to give rural youth in Indiana access to care within those four walls that they're in every day, which is the school building. We function neither, so Erskine functions neither as a healthcare provider or, you know, we aren't a school nurse or anything like that, but we're sort of like a third-party provider of these services. So we almost act as a project manager because rural providers and rural schools often don't have time to be able to write for grants and have a designated person to run these projects that are really valuable. So we are, again, kind of a middleman in that way. This all started with a HRSA planning grant that was awarded in 2015. And our intention was to simply lay the groundwork to establish a school-based telehealth network. We collaborated with a state Medicaid provider, rural schools, and rural providers in establishing this plan. And while all of that was happening, HRSA put out a 4-year grant application that was specifically for what we were working towards. So this grant would fund equipment, it would fund the time of someone from IRHA to be able to work towards implementing these telehealth clinics in schools. And so of course we ended up writing for that 4-year grant and were awarded it in 2016. And that grant actually ended in August of 2020, but we're continuing to help folks out as that comes up. We're going to go ahead and review what we're going to go over today. So we're just going to understand the benefits of school-based telehealth, talk about some key partners, look at workflows really briefly, look at a couple pieces of data, and then identify items to consider if you or someone that you know is looking to start a school-based telehealth clinic. So why telehealth? What was our interest and ultimately led to our decision in trying to utilize telehealth in schools? First, it goes without saying that there is a shortage of providers really everywhere, but especially in our rural communities. And so this was a way for us to connect rural schools to care and give these school-age children easier access to a provider that may or may not be in their physical area. This allows students to have regular and reliable appointments where they don't have to rely on transportation or major scheduling issues, which speeds up the process of getting an appointment, diagnosis, and potential treatment. And in turn, sooner. In a school-based a couple of years ago, they talked about if a child misses and you're in school around 10 months per year for the 13 years that, give or take, someone will, that would be 130 days of school, which is almost an entire year of school. And that was really eye-opening to me because, you know, sometimes these students might not be able to get into a provider, whether there's a transportation issue or a time issue or just an issue with scheduling. And so it has been really valuable for us to highlight that having this service within the school can therefore hopefully get the diagnosis and back to class sooner. Of course, if they're sick and they have to miss school, that's not something we can really control, but we want to try to decrease that missed school time. Another benefit is that it helps students establish good health practices. Students know that if they feel funny or feel sick or their ear hurts or if they feel like upset or anxious from like a behavioral health standpoint, that they're able to some degree have control of letting someone know that they need that care. Of course, there's parental consent, so they aren't, you know, being the ones that necessarily decide that, but they do know that they have access at school. I'll also add that it's almost been a sort of mini health lesson because with that telehealth equipment, they're able to see everything that's happening. So as the telehealth equipment's being, you know, put into their ear or held up to their eye, they can see that. I know I never saw my eardrum until I had access to the telehealth equipment. So it's been really awesome in that sense as well, is that they almost understand a little bit more of what's going on. On top of that, parents who have hourly jobs or parents who work a good distance away have the option to not have to leave work to be present at an appointment. And now I know, as a parent, I know that I would always leave work to be there for my child, but in the same breath, I'll say, if daycare called and said, hey, we have telehealth equipment and we think he might have an ear infection, I would, and we can see him here and then you can pick up the prescription on the way home. I'd probably say sure, because it's allowing the care to still occur and it's very efficient. So their child can have access to care even if the parent is in a circumstance where they can't get them physically to a provider office. And that to me is really valuable, especially for those folks that are really dependent on hourly wages or work over an hour away and can't do something like this easily. All of these services are billed to insurance, just like the visit took place in the physical office location. So you'll bill those normal CPT codes with the appropriate modifier in place of service codes. I will say that COVID has changed the way that telehealth is billed and a lot of the regulations around telehealth. So in Indiana, prior to October 24th, 2020, providers were actually utilizing two totally different ways to bill for telehealth. And again, not necessarily just in the school, but in general. So those that were listed in the Medicaid telemedicine service codes were being billed with place of service 02 and modifier 95. And then those that weren't listed prior to COVID were being billed with the place of service code where the visit would have taken place plus modifier GT to denote telehealth. And so now they've made it all the same. And so it's being billed as if the place of service where it would have taken place plus modifier GT. Kind of a complicated slew of billing information, but COVID kind of made it a little more streamlined, which not to say it's beneficial or not, but just an aside. I'll also mention that it is more cost effective than traditional school-based health centers. Not saying it's better than, just saying it's more cost effective. And that is essentially just because they're not having to hire a separate provider for this school-based telehealth clinic. They're able to utilize existing providers in those communities. And then again, finally, a huge reason we felt comfortable diving into this space is because we do house one of the TRCs, and they were able to allow us to vet equipment and identify what would work best in schools, identify regulations, and implement. Before we move on, I just want to say what telehealth in schools is not. This is not meant to take the place of a normal primary care provider. This is just meant to be an option, nor is it appropriate in every situation. It's not preferred over face-to-face. Again, we just have this as an option for those that want to utilize it or might need it. It doesn't take the place of the school nurse's normal activities. Rather, it adds to them, which we will talk about a little bit later. And currently, it's not being billed by the school. All co-payments are billed through the provider. So the school right now is not involved in any of that billing. Let's talk about key players in establishing a school-based telehealth clinic. A critical piece of success is making sure that you get all these key players in place and then making sure they're also all 100% on board, because it really has taken a village to implement these telehealth clinics. For success, it's been critical to get buy-in from the school all the way up, superintendent, principals, teachers, school board, school nurse. I will highlight that we didn't really realize this at first, but it's been really critical to make sure that teachers are educated and understand the program, because parents are mostly in contact with the teachers out of anyone in the school. And generally speaking, teachers are the ones that parents will trust most. They will seek out their opinion about certain programs that the school is offering. So once we realized that, we created a teacher education guide to be passed out, really whenever they wanted to do that. Some of them did it at those monthly teacher meetings. Some of them did an in-service about it. And then of course the school nurse is critical to get their buy-in as well, because they're the one that is championing the program. They're the one that is making sure that all of this is going to run smoothly once the program launches, and we really need their buy-in. Another key piece is ensuring that providers are totally on board. Providers being healthcare providers, the ones that are going to be providing that remote care. It always works better if the providers are brought in on the front end, because then they can become excited about the program and it's not something that is a surprise, especially if it's a larger healthcare entity. As far as funding for our specific project, we would not have been able to do it without funding from HRSA, Office for the Advancement of Telehealth, as telehealth equipment can often be costly, and having, again, that staff person to manage these projects can be difficult for a rural school or a rural provider that already has so much going on and is juggling so many different projects. Some of our schools were actually funded by the managed care entities in the state. We were able to achieve buy-in from all 4 managed care entities. And when I say that, they're just the Medicaid providers in the state. So there are also a few schools that have community grants and local things that can help fund that equipment as well.
Kathleen, we do have a question in chat.
Yep.
We might address right now. The question is, how many of the rural schools are taking advantage of the telehealth program? And does the school have to apply for the program? And if so, who do they go through to get more information?
Yep, so I will cover number later in the presentation, so you're going to hear me say it twice, but we have 39 live school-based telehealth clinics. They did have to apply through our application that we have on our website. However, I mentioned earlier that our grant has closed, so there's no longer, there's really no longer the same application, though if someone's interested, I can definitely help you to figure out if there's a way that we can work with you. So what the application looked like was essentially just identifying which provider you wanted to work with, if the school was around 50% free and reduced, or what that number was, because we did work with schools that were around the 50% free and reduced number. It wasn't required, it was just something that we were kind of placing precedent on. Did I answer all of your questions? Did I answer all the questions?
I believe you did, yes.
Okay. And again, application we can speak more to if someone's interested, but there was an application process and there was a way to go about getting involved with the program. So I'm going to move on to insurance navigators. In the communities that we've been in so far, we do sometimes run into families that are uninsured. So we make sure that if, a lot of times healthcare providers have navigators within their entities, but we make sure that if they don't, we have a partnership with Covering Kids and Families to help get those uninsured individuals coverage. So we made sure that those navigators were at, pre-COVID, were at things like back to school nights, parent-teacher conferences, really any event that they would come into contact with parents and students. And that was really, really valuable. And a part of the program that we weren't expecting was when you fill out that consent form, they were identifying their insurance. And sometimes they identified that they didn't have insurance. And that then led to them being connected to a navigator and making that process more seamless of catching those folks that didn't have coverage. And that was a benefit that was great, but we didn't know that was going to happen. And then finally, underlined and bolded, community support is huge. At every school-based telehealth clinic launch, we would do a ribbon cutting and invite the media. Many of our schools were great about promoting it via their Facebook pages, via local news, and others at community events like theirs. Again, pre-COVID, we could attend any of those events, but COVID changed a lot of the way that things were done. But I will just say that if the community doesn't know about it and they aren't excited about the program, then your program in your school isn't going to be successful, because I can be excited about this program and the superintendent can be excited and the provider can be excited, but if your community is not excited, it's not going to be successful. So just making sure that as folks are getting into this space, make sure there's a community outreach plan. Before we move into our services and our workflow, I want to look at this product of all of this background, which is just our telehealth clinics. Again, we had 39 school-based telehealth clinics serviced by 17 provider sites. As you can see, they were all over the state. We were able to purchase around 5 new sets of equipment per year, but at the end of, in our final year of our grant, we were able to purchase equipment for 14 new sites because of additional funding that we received. I'll mention again that we were able to collaborate with all 4 managed care entities, again, the Medicaid providers in the state. This was really valuable because it taught other folks how to establish a school-based telehealth clinic so that when our grant period ended, the model didn't necessarily end. And because we utilize local rural providers, we're not utilizing a provider across the country or something like that. There was really good buy-in from both a community and statewide standpoint. And I think that's why all 4 Indiana managed care entities were really interested in the program. And of course, as Indiana Rural Health Association, we are really passionate about rural healthcare, so wanted to make sure that care stayed local to those communities. And then again, before we move into workflows, I want to identify what telehealth looks like specifically for us. So the originating site is where the patient is and also where the school nurse acting as the presenter is. And the distant site is where the provider is located. The telehealth solutions that we use to connect the schools to a remote provider are usually web-based platforms with all the equipment and software installed on the school side. All the solutions we utilize have some sort of peripheral attachment so that the school nurse can act as the provider's hands. And those are here in this middle line, just an example of what some of them can look like. Normally, there are things like a general exam lens, an otoscope, a stethoscope. One of them had a dermoscope, just to be able to do the best diagnostic testing in a remote location that they could. We touched on provider side billing a little bit earlier. And again, providers at the distant site are able to bill, but to touch on school billing, just as we're kind of talking about these originating and distant sites, in the past, Indiana Medicaid reimbursement manual listed schools as a site that could not bill as an originating site. A couple of years ago, that was taken out, but they were never listed as a site that could bill. So as of March 2021, I believe there's a bill that's in the Senate that, if passed, would, as it's written now, allow schools to be able to bill as an originating site. I don't have all of the details on that. And of course, as with any bill, there's specific verbiage that would have to be followed in order to be able to do that. But it's something worth noting if you are interested in starting a school-based telehealth clinic. We start off the majority of our schools with the ability to provide acute physical care because there is that strong correlation between physical well-being and learning. My husband's an assistant principal at a school in Indiana, and oftentimes kids are acting out or not learning well because the physical health need hasn't been met. So the intersection between health and learning does have somewhat of a correlation, which is important to us as we worked to provide services in our school-based telehealth clinics. Our initial launch includes services for those acute physical illnesses that are common in schools. So I feel like I keep saying again, pre-COVID, but again, pre-COVID, things like flu, strep throat, ear infection, pink eye, rash, you know, right now, I don't think they're doing as much for those flu-like symptoms or sore throat-like symptoms because COVID has a lot of similar symptoms, and they're continuing to protect themselves in that way against COVID-19. As far as the grant goes, we don't have a preference for what telehealth solution our schools utilize, but of course we reviewed any technology that they planned to use, require that it's HIPAA compliant, video conferencing, and has appropriate peripheral devices to help the provider in diagnosing a student. I will note that the Erskine model, I know with telehealth, sometimes they're store and forward. With Erskine, these are all live visits. So just giving you an example of what the school side setup looks like. Again, this is just one of the types of equipment that we use. This is not our preference. This is not what is in every school, but the equipment is set up in a private space in the building, usually in or near the school nurse's office. And the equipment is located, again, at the school site. So the whole setup is at the school. Depending on the solution, they'll just need a laptop, an iPad, an iPhone, something to be able to have that audio video component. The provider side setup is actually really simple. All that's needed is a computer and a connection to a web browser. The clinician app is something similar to a browser-based HTML web app. I don't know what that means, but that's what it said in our fun documents that talk about technology specifications. If you're interested in that, I can provide that to you, but I can't speak to it. The clinician does have a login, so they will log in from a specific link, and that is essentially so that they can only access the assigned location so that there's no interception of appointments from other sites. What the physical health process looks like. So when the child presents to the school nurse will determine if the child would benefit from utilizing the telehealth clinic. This is not to take the place of what the school nurse normally does. They'll follow any of their other normal protocols for medications, scratches, things like that. Like, it's not student presents, we do a telehealth visit. It's not that at all. The telehealth clinic is only utilized when the school nurse deems that it's appropriate and helpful to utilize. And of course, if there's a consent form on file. So for example, if a child presented and was identifying that they had ear pain, the nurse in this case could determine if the child should see a remote provider with that telehealth equipment. The nurse would first check to see if there's a consent form on file, and they'll then call the parent to get a second verbal consent at that time. And the parent can either opt to have their child seen with or without their presence, or they can come pick them up and take them to, a physical location where their provider is. They then schedule with the provider office and soon after are able to see the provider at a designated time. The nurse will utilize the telehealth attachments, acting as the provider's hands. And in the case of ear pain, an otoscope would be helpful to diagnose something like an ear infection. After the provider sees everything, they'll make a diagnosis, call in a prescription as needed, send any follow-up that might be necessary, and the child, based on the diagnosis, is either sent home or back to class. If a prescription was called in, the parent can pick it up on the way home, because in that consent form, they list a pharmacy of choice, so the provider can have that all ready to go by the time that transportation would become available. In addition to offering acute care services, some schools also offered telebehavioral mental health services to their students as well. For behavioral health visits, the school and provider do these visits in a really simple way, which is just via HIPAA compliant video conferencing technology. While you could do these visits with the physical health equipment, if someone just wanted to offer mental behavioral care in the school, it's most cost effective to just do that with a laptop and, again, HIPAA compliant video conferencing. Because really for behavioral health visits, all you need is something like this, where you can hear and see the patient and provider back and forth. Each location has their own account, again, to prevent any overlap in appointments, intercepting of appointments, etc. And therapy was provided for things like separation anxiety, ADD, ODD, major depressive disorder, generalized anxiety disorder, and PTSD. To speak a bit to what this process looks like, there is a self, parent, or school referral, and then telebehavioral services are requested. There's an intake assessment to determine if it's the most appropriate means of therapy for this particular patient. And then therapy is provided in a designated private space in the school, and students are given a generic hall pass so that they can go do their telehealth appointment without necessarily drawing attention to what they're doing. As far as how providers determine who will utilize these services, they look for kids that are comfortable talking to screens, which in this day and age, most kids are. I heard a story from one of our providers that they were struggling getting their patient to progress. But when they switched over to telehealth with this particular student, they started to open up a little bit more. That could be because they had been with them enough. It could be because it was via telehealth, but we do love to hear success stories like that, because again, this isn't a service that's meant for everyone in every case, but it is a good option to have for students that it might work better for. They will also look for those kids with mid-level behavioral health concerns in hopes that they can catch kids here before anything else would get worse. And then finally, some behavioral health providers will look through their current patient panel and identify patients who frequently miss appointments. I was listening to a presentation recently, and it was not really talking about schools specifically, but relating to COVID and how behavioral mental health visits mostly went virtual. And there were 3 providers on that call, and they identified that there were less cancellations. So more people were keeping their telehealth appointments than were if they would have been in person. So it might have been a convenience thing. It might have been because we were all in our houses and had nowhere else to go. So of course we're going to keep our appointment. But again, I just think it's so interesting hearing how different individuals respond to different modalities of care. And I think that's something that we really have to keep in mind as we're looking at telehealth, especially because it is becoming way more of the norm because of how things have been over the past year. So we've just reviewed a good chunk of information about school-based telehealth clinics, and now we'll look at some brief numbers and data. I will say I was not the data person on this grant, so I pulled only things really that looked interesting to me. So what might be interesting to me might not be interesting to you, but we're going to talk about it anyways. So looking across here, you can see that from grant year 1 to 2, we had an increase, 2 to 3, we had an increase, and 3 to 4 in primary care, we had a slight increase, but in behavioral care, we didn't. And I just wanted to note that COVID-19 really impacted our grant and those numbers because the physical buildings closed of those schools. And so I will also say that when those physical buildings closed, because we utilized local remote providers, they were actually able to go grab some of that equipment from the school site and utilize that equipment during the state of emergency by putting it into places like nursing homes to allow folks to stay safe and socially distanced. So while our numbers did decrease from a school-based standpoint, that equipment was not going completely unutilized in an empty school building. And that is a huge success, in my opinion, because those resources might not have been available otherwise, and that might have prevented some people from getting care had that telehealth equipment not been available. And just so you guys can kind of understand, those visit numbers, on average, there are around 5 to 10 visits per month, and telehealth visits usually take between 10 and 15 minutes. And scheduling all is done by the provider and the school nurse. They were able to create processes that are really streamlined and quick so that the provider and the school nurse weren't taking a ton of time having to schedule. This I found really interesting because I know I mentioned that we were in schools that were around 50% free and reduced, 50% free and reduced. And that basically shows here that, there was 51%, actually, I need to minimize this, of commercial and private, and then the rest were Medicaid uninsured or some form of Medicare. And so I guess when we started, we thought that we would have a higher volume of Medicaid patients. So again, I just found this data really interesting in that there was also a really large, 51% buy-in from commercial and private pay billing audience. With anything that is telehealth, I think people are always wondering, was there lag? Could you see and hear the doctor? Was the visit actually successful? And you can see here that they understood and saw the doctor clearly. 88% strongly agree and 12% agree. I mentioned this a little bit earlier, and as a parent, I just find this really interesting that a parent would have had to use personal time to take their student to a doctor. 80% said yes and 20% said no. And then to review some of the parents' thoughts, because I think it's valuable to know what some folks think. Of course, these are all positive comments because it's my program, so we're going to be positive about it. I'm sure there were some that didn't love the program, but then they didn't have to use it. So parents' thoughts, so glad that they had this service. It's a great resource. It's convenient. They didn't have to leave work. Their child was seen by their own physician and prescriptions were ready for pickup. They loved their school nurse in the program. It's been a great benefit to our family. And then some items to consider if you are thinking about implementing school-based telehealth. One, a private space for the visit or portable equipment that's small and able to be moved around, because what's going on is essentially involving PHI. The visit can't be happening in the school nurse's office where there are a bunch of kids. So some do have the equipment in their office, and that's because they have like a waiting space or a place for students that aren't feeling well to sit outside of the office. And if that doesn't work, a solution that is small or mobile is the best option, because then that can really go to any private space in the school. For really both visits, but specifically when I made this second point, I was thinking of behavioral health visits. So there isn't someone in the room with the student during those behavioral health visits, but there does need to be, the room needs to not have a lock on it, and there needs to be someone kind of on call during that visit. So the behavioral mental health provider will have someone's cell phone number. So in the event that there would need to be a physical intervention, then that could happen. And then to add on to that, someone also sometimes has to cover for the school nurses, but school nurses usually schedule those acute physical care visits outside of their busy times because they usually know when things are more busy than not. Of course, there's a shortage of behavioral and mental health care providers everywhere, but especially in rural. And even if we did have a school that was interested, oftentimes it was hard to find a local provider that could provide that care. It can be a challenge right now especially with the way things are with COVID. I know behavioral mental care is even more of a shortage. Internet speed in rural Indiana, just something to consider. We personally haven't had a ton of internet issues or lag issues with the equipment. Some equipment does work a little bit better than others, but again, I'm not saying that every rural school will be able to have, the best internet or the fastest internet, but we have seen it work in the schools that we are established in. Staff turnover is something to consider. So, basically, if you implement this program, that doesn't mean that's the last time you're going to touch that site, because there might be a school nurse that retires or takes a different job or a provider that goes somewhere else. So there is maintenance that is required in these school-based telehealth clinics, especially to ensure that everything's up to date, they are properly trained, know how the equipment works, all of that. School site originating payment, we mentioned that earlier, and I'll mention it again because we did have some school corporations kind of say, this is a lot of work for us to do when they are using their space and their staff time and aren't necessarily getting reimbursed for it. But at the end of it all, they opted to provide this service because, as we know, folks that work in schools are doing what they do 100% because they care about those students. And so this program, while it doesn't necessarily bring in money for the school, it can help keep their students healthy. It can help reduce spread of illness. And it can even keep some of those habitual users of the school nurse's office, like I think I'm sick, but really they just want to get out of a test, or they're feeling like they don't want to be in class or something like that. It can help kind of identify or prevent some of that, because they know that there is a way to kind of see like they are sick or they are not sick. Having a plan to fund equipment. So again, providers are able to bill for this service, so that could be a way to fund equipment. But again, also looking into grants, community grants, things like that, not only to fund the equipment up front, but also usually there are yearly maintenance and renewal fees. So keeping that in mind. And then marketing and outreach plan. We talked about that a little bit earlier, but I want to stress it again, because this is something that the provider group that is establishing the school-based telehealth clinic will want to continue to be involved with that school, so that the school continues to have buy-in and the community continues to know about the program.
Kathleen, we did have a question chatted in. Are the school nurses performing the strep swabs and flu swabs under a hospital provided CLIA?
Yes. Short answer, yes. So in a couple of our sites, they don't do that at all, but in the ones that did do it, they either were brought under the provider's CLIA, and or they also were then, the provider would designate that school clinic as one of their like offshoot sites. So folks went about it in a couple different ways, but CLIA, putting the school nurse under the CLIA waiver of that healthcare provider was something that occurred. Good question. And that's all I have for y'all. Thanks for taking the time to learn about school-based telehealth. If anything comes up, here's my contact info. And then I just wanted to list out Indiana Rural Health's website, UMTRC, if you guys are interested. And then both of our annual conferences are this summer.
Kathleen, we did have one other question chatted in. Can you go into more detail about the telehealth training and demo site in Indianapolis, and who is the training all available for?
So preference as far as the training and demo center will go towards folks that are, of course, rural, but really anyone can. And again, I'm going to double check on this because it's Becky's baby, the UMTRC demo and training center. So she might be able, is she speaking for you guys?
Yes, she'll be speaking at our call convening meeting. So
I can answer that. I'm on.
Oh, hi, Becky.
Hi. Great job, Kathleen. So the demo center, we had funding, or the UMTRC received funding through the CARES Act to purchase equipment. And by the time all the equipment got here, our numbers last fall were getting so bad that we couldn't get in the office to get everything set up. So over the next couple of months, we'll be working on that. My intent is to have equipment set up at our annual conference in South Bend in July, which we will be opening up registration for that sometime in April. We're still working on all the details behind that. Kathleen's been a great help on our team for that. So big plug for the conference to come and see it there. But then when we bring it back in-house to the demo center, we'll start to open up times. At the beginning, we thought we would just do the access to the demo center with students or attendees that were there for training sessions. We may open up other times. Certainly, I'll put my email in the chat. You can certainly send me an email if you've got a group of people that you want to bring in. This will not be open to the John Q public, but by appointment, hospital employees and other groups, certainly we can make that available.
Becky, then a quick question. Is this where the school nurses go for their training?
No. So I'll go ahead and speak to that. Thank you, Becky. Okay. So for school nurse training, again, we purchase equipment for all of these sites. So the equipment is shipped to the school or we bring it to the school. And then either a trainer for that specific telehealth solution or staff at IRHA will go there and train the school nurses and providers.
Great. Any other questions? And again, feel free to chat in, or you're more than welcome to unmute your line and ask direct questions. This is definitely a great program and exciting to see how, sounds like it's worked well with behavioral health appointments for students and really cut down on the amount of time they have to spend out of school. And right now that's definitely a premium, so. I'm not seeing any other questions in the chat. If other things come up, definitely let us know. Want to really thank Kathleen for a great presentation today. This is a lot of good information, a lot of baseline information. Reach out for questions. Sounds like there's some opportunities to look at some equipment at the Upper Midwest Telehealth Resource Center annual conference as well. So we will close the meeting for today, and everyone stay safe. And again, thank you so much for everything that you're doing. And thanks to Becky Sanders for chiming in real quick to address questions too. We look forward to everyone joining us for the Critical Access Hospital convening meeting on April 22nd. If you haven't received a registration link to attend the virtual event, that will be from 9:30 to 3:30. I can forward all of the information about it, as well as our Part 3 series in May, which will go over clinic telehealth and some of the processes, workflows, and best practices there. So thank you all and have a wonderful rest of your day.